Okay. Hello everyone. If you're joining us online on any of our platforms, I am seeing that we're going live right now. So hopefully you should be able to see and hear us. Welcome everyone, and thank you for being here. Um, my name is Christine Rodriguez. I'm the Senior Program Manager for Harm Reduction here at AIDS United. I have just a little bit of housekeeping, and then we'll jump into our conversation today. My pronouns are she, her. They're right here at the bottom. And I have the distinct pleasure today of welcoming Daniel Raymond, who right now is the Director of Policy at the National Viral Hepatitis Roundtable, but had joined them with a 30-year history in harm reduction ish. So we won't do math, but I'm really excited to have a conversation with Daniel today. This morning's chat is part of a series that is happening across the day today, across AIDS United, our different sort of portfolios of work to commemorate World AIDS Day, December 1st every year. And they're also part of our Partnering and Communicating Together initiative, known as PACT, which provides messaging and resources for HIV prevention, testing, and treatment for community and for providers. If you're interested in that, you can find out more information by following the hashtag Stop HIV Together or visiting cdc.gov/Stop HIV Together. There it is on screen. Beautiful. And so there's an annual theme, right, every year for World AIDS Day. And this year's theme is achieving equity to end HIV, right? And so I don't know, I thought this was a really interesting theme to go with this year. I feel like equity is really on folks' minds, sort of at the forefront of how we keep talking about wanting to, have an equity lens, that we need to do equity work, ensure equity in our work. And so I'm excited to talk about this in part because Daniel, as you said to me before when we were talking through this, that you are interested in the questions that don't have easy answers and don't shy away from those questions. So I'm excited to have maybe a little bit of a different conversation about equity. And this could be in terms of racial equity or gender equity or equity for people who use drugs within the broader HIV response, right? Because we won't end the HIV epidemic without people who use drugs and without sex workers and without our communities, right? Um, so first, before we get started, is there anything you wanted to say by way of introduction? That I don't have a bio I'm reading for you, so if there's anything you want to add, please do, and then we
Yeah,
can go ahead and get
sure.
started. Yeah.
Yeah, thanks, Christine. Really happy to be here with you and with the broader AIDS United community. In various ways, AIDS United has been just such a strong force to be reckoned with, ally and a partner, and not just a leader, but also various people within AIDS United, currently and historically, are people that I've considered friends, partners, mentors. So, really glad to be
Mhm.
here. And for people who aren't familiar with National Viral Hepatitis Roundtable, we're a little younger than AIDS United. We turn 20 next year. And we were formed as an umbrella network to bring together a growing coalescence of different kinds of groups, stakeholders, advocates working on hepatitis B, hepatitis C,
Mhm.
immunization. And so we are a small team, and a few years ago, we formally became a program of hepatitis education project in Seattle. So we have a
Mhm.
nice institutional home, but I definitely feel like we are walking in the footsteps of previous staff, such as Miss Christine Rodriguez, who did a
Mhm.
stint at MHR many years ago, and that's around the time I think I met you slightly before that. So this feels like
Mhm.
a full circle moment.
Circle, lovely. I love it, and I really appreciate you being here, coming from a more specific hepatitis lens. Now, a lot of our work is really intertwined and inseparable. If we talk about like a syndemic approach, or the syndemic of HIV and viral hepatitis and fatal overdose, a lot of our values are really aligned and a lot of our goals also feel aligned. But so, in starting to talk about equity, um, it feels like one of these words that we all use and rarely sort of define, right? And so, we're talking about NVHR developing equity principles. AIDS United talks about inequity and righting those disparities and injustices. And it feels like a lot of organizations have been thinking more about equity and justice, these two like related but not quite the same concepts, especially since the uprisings after the murder of George Floyd, right? And so it raised the question of like, what does equity look like in practice? Because I've seen so many wonderful statements about equity. And so then when theory and practice come together, when we talk about praxis, like how we live those values in our work, whether it's in our organizations or in our external work, I'm wondering about like what your thoughts are about how we can sort of effectively put values around equity into practice, either internally or externally, or whether that feels like an open question to you still.
Yeah, I think it feels very much like an open question that
Mhm.
I feel almost somewhat mistrustful of anyone or any group that's prematurely decide, oh, we've got the answers, we've got the formula. And I think that
Mhm.
coming into NVHR, I joined a few months after um, our director of programs, Adrian Simmons. And so we started off last year saying, well, okay, it feels like the time is right for us to map out our strategic priorities for the next few years. And we weren't
Mhm.
starting from scratch. We were carrying on work that had been done for many years. Networks of relationships, coalitions, and a set of articulated and expressed values, which one of which included equity. And we
Mhm.
were doing this work also shortly after the Department of Health and Human Services released their updated viral hepatitis national strategic plan,
Mhm.
which spent a lot of time talking about disparities and equities. So, our broader overarching vision was that we want to help align and catalyze the work that's happening around the country and accelerate progress towards eliminating viral hepatitis as a public health threat by 2030. World Health
Mhm.
Organization goal, very analogous to the epidemic work in HIV with certain metrics in terms of preventing new infections and mortality and so forth. And so looking at how equity was woven in both the HHS strategic plan, but also the MVHR's values that we'd inherited, we
Mhm.
started asking ourselves, well, what will that mean in practice? Because we were really focused on maybe not a full-fledged strategic planning, but a strategic prioritization process that really should guide us in terms of where we put our focus, where we put our energy, who we build with, and what kinds of outcomes we
Mhm.
want to see. So I think that that led us to a process where we said, well, it's great to say health equity in general, but what does that mean for viral hepatitis? We knew, and the HHS plan certainly documents and
Mhm.
articulates that we see uh, a whole range of health disparities across various categories in terms of viral hepatitis, specifically hepatitis A, B, and C, and that it becomes a really interesting, almost like a sort of case study or laboratory for saying, well, what do you do when you know that there's a high prevalence of hepatitis B among certain foreign-born communities, that we see excess mortality from chronic hepatitis C among Native Americans, among African Americans. We see
Mhm.
cross-cutting themes in terms of people with HIV, people who've experienced homelessness, incarceration, people who use drugs, uh, things like immigration status. So all of that suggested that we can't just kind of make a little banner saying we love equity and hope for the best. That
Right.
we really want to kind of dig into how we actually achieve that. And I know that in my thinking, I took a lot of lessons from the HIV side. I think that there's been a great deal of funding and activism around research in HIV, looking at not just documenting disparities, but testing out
Mhm.
different kind of strategies, as well as really trying to understand some of the root causes. So how do we move some of those numbers and change them? We know that a lot of for example, when we see some kind of innovation in the space of healthcare or public health, the people who initially benefit from it,
Mhm.
that's not a cross section. It's not evenly distributed. And, I think a lot of people saw this over the last couple of years in big debates about vaccination strategies for COVID, or more recently for monkeypox, that
Mhm.
uh, it really requires some care and attention to having strategies tailored to different people in different places where there are different structural constraints or systemic barriers to access and to better health outcomes. So
Right, right.
it's an ongoing process for us where we really don't want this to be lip service. We really want to dig into what kind of policies, what kind of strategies, what kind of investments will benefit the groups that are bearing a disproportionate share of the burden, but also really
Mhm.
kind of breaking that down and asking why, we know that there's no specific, for example, genetic or chromosomal, or, the disparities that we see aren't in the bodies,
Right.
but in the systems.
In the
And
systems, they're social. Mhm.
yeah, and getting really clear about that people who live in communities that are disproportionately disinvested from, have fewer job and educational opportunities, or pushed out of school, and end up being heavily policed and higher exposure to arrest and incarceration. Those are the structural factors that start to shape the ability of people to navigate risk of hepatitis C or HIV. And so
Mhm.
interrupting those places, and ideally kind of painting a more aspirational picture towards a broader transformation, uh,
Mhm.
is the way that we can actually start to get concrete and make meaningful changes around the equity goals that we espouse.
Yeah, yeah, I like that, and I really like putting sort of intentional thought into who we build with, because we're all doing movement work, and a lot of times those movements are overlapping. um and who we build with, I think, is really important, and trying to shine sort of light on who we're not building with, that we should be. um as someone who works in policy, like, you can start with a disparity, like a health disparity, and
Mhm.
you can start connecting dots to, potential reasons why the disparity may exist. Whether it is, stigma, access to care, like the health system isn't reimbursing for some, like, whatever the case may be, you can, like, draw it back. How do you decide sort of when to stop drawing the line back for your work? Because you can sort of
Yeah.
draw it then to homelessness, to racism is the big one, right? And, like, so we talked about how organizations are getting these sort of more and more grandiose missions about dismantling systems and things that
Mhm.
are really hard and need to happen in like collective sort of action. And so, like, where do you draw a line, sort of, as an organization or as like in setting your policy priorities in terms of
Yeah.
how far you're willing to impact the root cause?
So this is my theory, and this may be somewhat tautological or self-justifying, but one of the things that really appealed to me when I came into MVHR, when there had already been this vision set around eliminating viral hepatitis as a public health threat by 2030, is the clock is ticking. We
Mhm.
don't necessarily have time to, the word that I was going to use may not be the one that AIDS United would want to broadcast. It's screw around. We don't have time to
Yeah,
screw around.
yeah.
So there's something there that's kind of sharpening, that is part of our vision, that homelessness will be ended by 2030. No. That mass
Mhm.
incarceration will be ended by 2030. No. So if we assume that those conditions are still going to obtain, and that while we want to do what we can to chip away or erode or educate around the value of tackling these broader structural issues, we can anticipate that eliminating viral hepatitis as a public health threat by 2030, in the year 2029, that is going to mean doing some work with people who are incarcerated, doing some work with people who are houseless. And so
Mhm.
that starts to kind of narrow your focus to saying, let's make sure that we are really rigorous about having the most impact that we can. So we were talking with
Mhm.
one of our core partners, Harvard Law School Center for Health Law and Policy Innovation.
Mhm.
We work with them on what's broadly known as the State of Hep C report, which assesses Medicaid access to the medications, the direct acting antivirals that are used to treat and cure hepatitis C on a state by state basis. And
Mhm.
that, for me, represents a great example of where there is this systemic barrier that disproportionately affects people who are overrepresented in terms of Medicaid beneficiaries, that map
Mhm.
onto a lot of structures of disadvantage. Um,
Totally.
we know from data that CDC put out a few months ago that compared to people on Medicare or private insurance, people on Medicaid are less likely to initiate hepatitis C treatment within a year of diagnosis, right? So that is one
Mhm.
of those kind of slices of saying, well, we can say that this community has higher rates of mortality, but what's driving that? So we're looking at the
Right.
drivers here in terms of Medicaid and how that shapes conditions for access to care. And we've seen tremendous progress um, through not only that project, but broader advocacy networks, in terms of removing barriers. Enough
Mhm.
so that we got to a point where we said, well, let's look forward a little bit. We can't just expect that these dominoes will continue to drop as more and more states ease up and remove prior authorization. We have our work cut out for us, but we can envision this place where we're asking ourselves, where can we take this next? And so a lot of that
Mhm.
conversation was really about balancing, where could we have the most impact? Where is there energy amongst our key stakeholders and constituents? And how do we balance those two within this broader vision of equity? So that, balancing that question, as you said, Christine, who do we want to build with what's
Right.
going to get us where we need to go within a relatively limited kind of, we have the people that we have the resources that we have. And while we could get more people in terms of staffing or more resources in terms of funding, that we probably, you know, will do best if that's aligned with the vision of what our lane and objective is. And so that's how we
Mhm.
start to kind of navigate those discussions of making sure that we're not going too broad and superficial and trying to cover the entire waterfront. There's groups that we can collaborate with that do that. There's efforts that we can support and amplify that are doing that, but what's our
Right.
particular contribution here? And really stay uh, very dedicated to that lens.
Totally. And I guess this sort of just occurs to me in terms of prioritization and kind of using disparities, data, information. Um, it feels very similar in viral hepatitis and HIV and drug user health that you are you end up advocating with and for a lot of different, very pushed to the margins, like oppressed peoples, right? Like there are Black folks, Native folks, other people of color. There are folks
Yeah.
with incarceration histories, homelessness experience, like all all of these sort of buckets of vulnerability that also overlap. Does it does it ever feel challenging trying to balance making sure that you're feeling like you're showing up for sort of all the communities that are impacted that you want to? Because I know that's a tension I struggle with pretty
Yeah,
often. Like, who am I leaving out? Who am I forgetting? How can we show up better? And I
yeah.
struggle because it's a lot.
I think there is something about this work that constantly requires a certain discipline or practice of openness and humility. Um,
Mhm.
I remember when I started doing federal policy work, probably nearly 20 years ago,
Mhm.
on hepatitis C and on harm reduction. Um, that it was I had come from a primarily direct services background, and that doing policy work brought me into rooms, into forums, into settings that were very different than that.
Mhm.
And in many of those cases, in terms of my own personal history around injection drug use, that I was the only one. And
Mhm.
I was acutely aware of the limitations of that, right? That, I think there's, the obvious kind of superficial, I'm a white man, that is a subset, and that the impacts of criminalization of stigma, are very much, mediated by gender, they're racialized, all of that stuff, immigration status. So
Mhm.
there were things that I could kind of theoretically try to kind of keep in mind, but if I tried to kind of set myself up as, okay, I will be the voice of lived experience here, then that just wasn't going to work. And
Yeah.
I think that, that ultimately kind of took me to in a couple of different directions. One was that, really questioning, why was I the only one, right? Why weren't
Yeah.
there more of us? And how do we kind of open up those forums? But also to be, highly skeptical of you know, that kind of delegational role, right? That there are things that I felt obliged to kind of bring to the table in terms of broader channeling of community voice, community concerns, community priorities,
Yep.
and that I had to work on my own skills because people were counting on me or whoever was that person in that room on that particular day to do that as well and as accountably as possible. But I think there was also a piece where, I would, be in some settings where it was a kind of bit of a sort of a parade of, and, now let's consider the needs of community X, community Y, community Z. And I think that, you see this sometimes in HIV planning groups, right? Or in, say, if the
Mhm.
Presidential Advisory Commission on HIV/AIDS has a public testimony, and I'm here to speak for adolescent girls. I'm here to speak for Pacific Islanders, and I think that. that there's a way that the system rewards that kind of approach that still ends up, I think, keeping many of us feeling like we end up still being kind of pitted against each other or played off against each other.
Mhm.
And I think that it's been important for me in my work to kind of recognize that whether we're talking about, uh, you know, gender, race or ethnicity or national origin, like all of these kind of categories, that there are ways that we're each like and unlike each other. There's ways
Mhm.
that we're like and unlike the person that we think we are, or that we've been, or that we want to be. And that kind of pulling at some of those threads and grounding our work in shared values, building a shared analysis together. Um,
Mhm.
and, you can keep asking, whose voice is missing, who's not at the table. But there's, a
Mhm.
certain trap that we fall into when we ask people to be that individual voice that will provide the answers for us, right? Instead of
Absolutely.
do the hard work and thinking with us.
Yeah, absolutely. It feels like each sort of individual is set up to feel very tokenized,
Mhm,
despite the sort of broader group being diverse, right? And it's really I feel like it's really interesting in our work in harm reduction. We were talking about this before and talking about sort of the ideas around equity, around identity, lived experience, whether or not you're being meaningfully involved, and like meaningful inclusion is like a really core value of AIDS United's work, right? And so wanting to really do that in in a more profound way than just sort of ticking off boxes, right?
mhm,
And when we talk about uplifting the voices of people who use drugs, centering the leadership of people who use drugs, um, I think that's really an important idea for equity's sake. Like, if policies and programs are impacting you, you should have a say in what those look like, right? And it feels like in harm reduction, and maybe more broadly also, when we say people who use drugs, I feel like we have a certain it's a euphemism for something more specific that we have in mind that we are not articulating, like the type of panelist you'd like to see speaking at an event, or the type of experience that you want brought to as a lens to some sort of analysis. Um, but we don't talk that specifically. And you used a phrase that I really liked, that was the politics of deference
mhm.
come into play a lot in these sort of circumstances. I'm wondering if you could talk a little bit more about sort of what you mean by that.
Yeah, so I absolutely won't take credit for this phrase. This came out of an interview I was reading on Truth Out, between Kelly Hayes, who's an organizer who does great interviews, um,
Mhm.
uh, under the kind of heading movement memos, with a philosopher, Olufemi Taiwo, who has a new book
Ugh,
out
that I
called.
still need to read. Yes, thank you.
Well, I will say I have read the interview. I have not read the book yet, but
Okay, great.
his book's called Elite Capture: How the Powerful Take Over Identity Politics. And it was very helpful for me in kind of thinking through some of the things that have been in my mind and talking about people in the drug user organizing world and some of the work that Urban Survivors Union has been doing, and s- sensing this kind of frustration around that, lived experience, lived expertise kind of issue that you mentioned, but also just like some broader dynamics. We partner with NASTAD, and with NACCHO on a CDC funded initiative called HepNet, where the
Mhm.
goal is to help communities to strengthen their ability to do to respond to hepatitis C amongst people who use drugs. And from the very beginning, one of the reasons that we were excited to get to work with NASDAD and NAIDS was not just the fact that they have great people there and they have reached to state health departments and to city and county health departments, but that when we came together, we recognized that we had some shared values, including around meaningful involvement of people with lived experience.
Mhm.
And then, as you start to kind of go beneath the surface, we've been putting those values into practice in terms of how we structure it. But what we see on the viral hepatitis side is that many states, probably at this point, most states have either released or are producing some kind of hepatitis C strategic plans. Sometimes it's HIV and hepatitis C, like Indiana's Zero is Possible, or California's syndemic plan. Sometimes it's hepatitis B and hepatitis C. Sometimes it's just hepatitis C. And, they often convene a planning group and made up of public health people and clinicians and healthcare providers and different stakeholder groups. And so there's always this kind of demand, and we need a few seats, or at least one seat for the harm reduction person, the patient, the person who uses drugs. And what an impossible situation that is, right?
Mhm.
That uh, that that is our end game to say that we'll just continue to advocate for a kind of token level of representation and inclusion and just hope for the best, right? And people in those situations are often kind of put under incredible scrutiny, incredible pressure, and you always have to ask yourself what were the pathways through which those particular people got those particular seats. Through no fault or to discredit them, but some of them kicked open the doors, but some of those doors were held open for them by virtue of the fact that, for example, they went to college or they are not, a mother raising small children that she's afraid of child protective services getting called if she talks about her experience as a drug user. So she is not going to raise her hand to say, yes, I will be the public, visible, outspoken person who uses drugs on your advisory committee. So all these kind of
Right.
different traps where if our core demand is that that these advisory boards, these working groups, these committees, these councils have to have inclusion of the person with category X, then that almost detracts from the demand or focus on how do we build power outside of those structures amongst broader communities to hold those structures accountable to our demands instead of trying to channel our input, our ideas, our asks through the different kind of bottlenecks
Through their
that
structures.
yeah,
Mhm.
exactly. So I think it's that kind of tension that, I'm trying to, you know, continue to work through. The answer is not to say we shouldn't have representation or voices in those structures, but
Yeah.
it can't end there. And
Right.
it,
Right.
and that I think a whole lot of energy sometimes goes into that kind of symbolic representation that does not actually translate to meaningful power and change.
Yeah, absolutely, and I feel like that's a point that, I can only see certain comments come through this system, so apologies if I'm missing some, um, but Morgan's point, talking about meaningful involvement going beyond being relegated to public speaking, which
Yeah,
is often just sort of, yay, a chance to relive your trauma. Um, but it includes like well-paid work and leadership pipelines.
yeah,
Um, and I feel like we could do a much better job about sort of leadership pipelines. Um, in a bunch of like a lot like it would have to take a whole sort of movement wide um move, right? That's not anything one organization can solve. But I'm something I feel like I've been thinking about recently is sort of, I mean, for equity's sake and for other reasons, when we talk about equity in folks who use drugs, the importance, or it feels important to me, um, w- that we have a shared understanding of sort of what we mean when we say certain things. Um, and I don't know that we have like an agreed upon what we mean when we say people who use drugs.
Hmm.
And it feels very contextual what we mean. Um, and sort of speaking to both Morgan's point that there needs to be a sort of, the whole range of possibilities for folks' employment and leadership, and the realities of both societal stigma, criminalization, and internalized stigma. There very well may be more drug users in these positions than we even know because they're afraid to disclose. And I don't know, there's sort of something around using this as a euphemism and like combined with a lot of stigma sort of within the community that makes me like a little unsettled. And I'm not sure
Yeah,
what it is exactly that makes me feel unsettled about those two things existing at the same time.
yeah, I hear that. I mean, I think there is uh, obvious critique, and I think that Morgan's comment kind of builds on that too. That this is a structural issue, right? And that we need a systematic response to it. That we are kind of looking around and seeing how it's going, maybe kind of organization by organization, group by group, and that taking a kind of broader approach has to be more effective than the kind of piecemeal strategies that we're doing that often are fragile or precarious or short-lived, or in the kind of scenarios that you're talking about, the thing that I've heard so many times from people who use drugs in the harm reduction field is that um showing up late to work, right? um For other people, yeah, the subway broke down. For them, it activates stereotypes about
Exactly.
reliability, about responsibility, about professionalism.
About truth telling.
Yeah,
Sure, the subway
exactly.
broke down. Again, like,
Mhm.
yeah, the subway breaks down all the time, right?
Yeah,
So,
yeah, and I think I don't know if this is the right way to frame it. I like your word "unsettled," that, um, I I I think that we should stay unsettled about these dynamics, and I find myself asking more and more, do we address these as upstream or downstream? In the world that we want to see, is changing that a necessary precondition to getting where we want to be? Or does the
mm,
process of getting where we want to be start to unweave that kind of tapestry of the things that are holding us back? I My feeling is that especially in the kind of
mhm,
nonprofit world over the last few years, that there's been this kind of big call to pause and say, no, we need to treat these things as upstream until we get like until we do this internal work, we're never going to get to so it's the kind of idea of sort of a prefigurative politics almost. And at the same time, I think that we've seen many of examples of that um, being paralyzing. And I think it's kind of
mhm,
complex to kind of tease out cause and effect here, and that's why I've been kind of looking to Femi Taiwo's work to think about different ways of thinking through and thinking with what that looks like. But I I think that there's clearly, a need to be responsive and attuned to demands coming from drug user organizers around actual labor conditions, about actual needs for support, for professional development, about actual opportunities to transform the workplaces, and that we are also in a moment where the demands on our work are vast, just, even just looking at the overdose numbers, and
Yeah,
that it would be, I think, an equally great mistake to treat those as two separate things and say, well, we'll do number one first and then we'll do number two, that
right.
they have to kind of go hand in hand. And I think uh, the the process has to kind of unfold, maybe maybe it won't always be in tandem, but that
Mhm.
both of those
But
are gonna
somehow
be
in
necessary.
parallel,
Yeah,
even
or
if
at
they're
least
not at the same pace, that they're still sort of
yeah,
happening at the same time.
yeah,
Mhm. Mhm. Yeah. I think about internalized stigma in our community a lot. Um, and in terms of, equity for people who use drugs, I don't know, it feels um something about being able to model what we extend to participants and what we say about our programs to agencies, like to be able to extend that to each other more often in more ways. Um, I don't know. I would like to see it. Um, I feel very worried about our community,
yeah,
and all of this feels very urgent. Um, when it feels really urgent, our young folks, like, new ideas, they're dying like fresh eyes. Our, like, long time folks that hold our history and are like what's worked and what hasn't, and they're dying, right? And so, like, I don't know, for equity for folks who use drugs, like, there's all of this work that we are and can do. And what about, like, ourselves, right? And being able to extend some of that, like, space and grace to each other.
yeah. I
I don't
I mean,
know.
in so many ways, the work is hard, and that so many of us kind of came up through it, um, for reasons that tap into, you know, love, but also, you know, I think maybe a search for wholeness, right? That the best harm reductionists can recognize the hurt and sometimes fractured or broken places and spaces in other people because we felt them in ourselves. Um,
Mhm.
and I think that can often make us highly vulnerable, in many different ways, and that we haven't always honored that. And I think there's also, uh, a an issue here where we need to, find different ways to be with each other, and the lines that we draw around who gets to count as us, as each other, that I think, uh, I'm putting a spin on it, but that Justin's kind of calling out here is, something that maybe, is sometimes served well by conceiving of drug users as a class of people, a group of people, an identity, and sometimes it's
Mhm.
not so much served well.
Right.
I
Right.
think back to my early days of doing harm reduction and working at a certain service program, and I was just as likely to connect with people over, comic books or professional wrestling or whatever than I was over
Totally.
heroin or meth. Um, and that I think sometimes if we want to take more risks, then some of that means kind of owning our stuff, owning our boundaries, in ways that aren't just about protecting us, but protecting other people from some of the harder parts of us as well
Yeah.
that may lash out or may still be kind of struggling with things. But that kind of grounding gets you to a place where the parts that you can share, that you can open up, feel more nurturing, feel more uh, supportive, and ultimately, hopefully, healing.
Mhm. Mhm. Yeah, I really hope for that too. I keep thinking about what working toward that looks like in practice, right?
Yeah,
And I often come up really short. Um, I know I can talk to people who I know, which, is just like a tiny little sliver of community. Um, but it's rough out there, that internalized stigma, the drugs hierarchy, the exceptionalism that some folks in like marijuana or psychedelic spaces have engaged in the past, may still do, like, does not help. And yeah, I don't know. I want us to be okay and
yeah.
be able to do the work that people need us to do and that we
Well,
ourselves feel called to do.
yeah, I think part of it is also about stepping back and saying, maybe it's not just us, right? Look at how hyper polarized and partisan the rest of the country is. Look at what we've been through over the last few years, uh, the toll of the overdose crisis, where we've all lost people that I think many of us, if we're honest, have not had time to fully mourn. You
Grieve
know,
properly. Yeah.
magnified by the COVID pandemic, by the everything, and that who does it benefit um when we're fearful? Who does it benefit when we're divided? Who does it benefit when
Right.
we are kind of fighting for scraps or fighting for attention or jockeying for position? And there's a place here
Mhm.
where we need to kind of own our stuff, but there's also a place here where if we're going to find ways to resist that, to reverse that, then it's not so much that harm reduction is going through a particular period, it's that everyone is, right? And it's manifesting in particular ways at the very moment where harm reduction is more needed than ever. And yet, the progress that we've made collectively over the last 5, 7+ years
Mhm.
is on the brink of what could be a substantial backlash. So
Right.
I think that those dynamics, those tensions, that complex sense of being in multiple spaces at the same time, of seeing that harm reductions come further than it ever has before, and yet it feels so much more fraught than it has, you know, overall in a long
Yeah.
time. It's a very challenging place to be in.
It really is, and it is just it's so much for us to be doing it to ourselves as well, and I just I don't know, I feel like I always personally need to try and keep a sense of perspective or something, because so much can distract from the work, so many little side things and personalities and whatever things folks get into, right? There are like little beefs all over the place. Um, and like that's the kind of work that the state does, right? That sort of fomenting discord internally within movements and spreading sort of rumors and like doing this sort of infiltration is common. And I don't want to who who put this who put this to me? It might have been Jess Cochran. Like, don't do the state's job for it, right? Like, let's let's find other ways. Like, I think, like you're saying, I think this applies too. Like, let's find other ways to be together and to work through the like inevitable hard things that are going to happen in movement work because it's messy. But there, like, has to be something on the other side where there's also, like, that care. And not to say that that's entirely missing. I feel like I want to see it more present, I guess.
Yeah, I think one of the more structural vulnerabilities for harm reduction is that from the kind of initial days of sort of the formal history of syringe exchange in this country, going back to the late 80s, that I think that a lot of us quickly got absorbed and funneled into the nonprofit space, right?
Yeah.
And so that, has a particular relationship to the state, and that for a lot of people, their nonprofit organization became their movement home, their political home, their spiritual home, the place that, you know, all of that stuff. And I think that there's an opportunity here if we want to think of, harm reduction within across, but also beyond the state, to really think about what beyond the state looks like in
Mm,
terms of building anchor points for harm reduction that aren't so dependent or vulnerable on formations that already have these particular structural relationships to to the state, such as nonprofits. And this is not a call to
mhm.
abolish nonprofits. I work for one myself, but
Totally.
to also think about how,
There are
I work for
limitations.
one, right? And so there's a piece of me that is, going to be invested in my job. And there can also be a piece of me that has a different relationship and investment to harm reduction outside of my job, whether
Yeah.
that takes the form of a mutual aid group that is never going to request 501c3, or whether that's in the form of getting involved in movement building work that may not have harm reduction or people who use drugs in their name, but if I and people like me start showing up, that may surface or rise in terms of their agenda and their
Right.
organizing strategies. So I
Right.
think
But
that,
somewhere where there are aligned values
yeah, so I think that
underlying
there's
the
a
work.
place
Mhm.
to see as harm reduction in many ways gets more integrated into the state, taking a more fugitive strategy and finding spaces outside to continue to build so that those vulnerabilities are less structurally overdetermined and that there's more space
Mhm.
for us to be together
Yeah,
differently.
absolutely. Um, are there I don't know, are there any spaces outside the state that have existed in the past that you've been a part of? Or that I don't know, are there any sort of models of that you have liked, that you miss, that you wish would resurface or never again? Or like, where do you look for
Yeah, so I mean, my kind of political origins go back to the you know late 80s, early 90s period of AIDS activism where I got involved
Mhm.
with ACT UP in New York. And
Totally.
I hesitate to kind of make any claims. Oh, that was this completely autonomous group. We blah blah blah. Like it was a very structured group, and it had very kind of complex, like legacies that from women's movement, civil rights movement, anti-war activism that informed how it operated, and that it was, this kind of idea that's somewhat mythical of being, oh, I'm outside of the state. Well, we're not on a boat, right? We're not in the middle of the ocean.
Right.
That and many of our demands, not all of our demands, were demands to the state. So I think that, but I think about that legacy of a particular kind of coalitional politics that was very influential for me.
Mhm.
And I think some more recent work in terms of the overdose crisis has really kind of shaped my sense that harm reduction, we can't quarantine ourselves, right? That
Mhm.
we're going to, we have a mandate to be talking to people, both like and unlike us, where we may not want to work on other things together. We may have radically different commitments, personally, politically, ideologically. And yet, if we can find some common ground in terms of shared values, that we can make something happen together, even if it's just for now.
Yeah.
And that at least if we can stay in conversation with each other, stay in community with each other, um, without any preconceptions about where that's going to go, that's the really difficult part of coalitional politics. And yet, when it works, it's uh, frustrating and transformational.
Yes. Yeah. Yeah, it is. I've seen some very, very, like, at least in the moment, flash in the pan, very angry sort of activist meetings that just dissolve afterward. It's because there is righteous anger out there in the community, and I feel like that anger also needs somewhere to be expressed, and I don't know, family gets the brunt, tends to, like, get the brunt, right? Your chosen or your biological family of your moods or whatever the
Hmm.
case may be, and I feel like we do that to each other a bit. Um, we do that to each other a bit. Um, it is, like, somehow magically 3 minutes to noon in on the East Coast. Um, I don't know, any sort of, like, parting thoughts or questions to leave folks with or anything along those lines before we close out our hour together?
Yeah, well, I will. Uh, I'm contractually obligated to make a final plug for National Viral Hepatitis Roundtable. We would love to try to model some of the stuff I'm talking about in terms of equity and coalition more with people and groups working on HIV, working in harm reduction. I think that we're really excited about the opportunities in front of us, and I know that I do my best work when I'm talking to a lot of different people, listening to a lot of different people, and helping to build new spaces for people to talk to and see and hear each other from. So I will make a pitch for, the old round table as a place that could maybe be your home away from home.
Yes. NVHR, National Viral Hepatitis Roundtable, nvhr.org. Look it up. Yes, thank you for the banner right down here. You can find us anytime at aidsunited.org. If you want to reach us, harm reduction at aidsunited.org. We'll get that to the team. I'm so grateful for your time and thoughtfulness. And just thank you so much, Daniel, for joining me today. There are a series of conversations happening through the day, um, ending with a virtual vigil later this evening. So please check our social. There's information about other chats, the vigil, etc., throughout World AIDS Day. Um, I hope everyone has a really lovely Thursday. Um, Thank you for all the work that you're doing out there to end the HIV epidemic and or viral hepatitis and or fatal overdose. We so appreciate your work and being in movement with you um, to do that. And now that it's noon, I think we will just close it out. And we'll see you next time. I hope you have a lovely way of commemorating today, however makes you feel good and feel heard. So thanks again, and hope to see you in our other chats later today.
Thanks so much, Christine.